Hi, I'm Dave Fernald, a digital editor of Cardiovascular Business. I'm with Ami Bhatt. She is the American College of Cardiology Innovation Officer and an adult congenital heart disease cardiologist at Mass General Hospital. And she was the former director of telecardiology at Mass General Hospital in Boston when the COVID pandemic hit, where she took the lead in telecardiology and became a national expert on this. And I wanted to find out from you what hospitals need to know if they're going to create these types of programs and how to manage them.
Absolutely. Well, thanks for having me today. It's exciting to talk about telecardiology. I started my practice in 2013 because I took care of younger patients, adults with congenital heart disease who were, in their 30s and busy with kids and job and didn't really want to remember what it was like sometimes being a kid in the hospital. So it was out of necessity that we did that. That same thing happened to everybody during COVID. And one thing we're seeing now is there is a regression to the mean, right? We don't do 100% virtual visits, phone call or video anymore. We're going back to some inpatient or in person rather, versus blended care, right? Which is the phrase that I like to use, which is thinking about sometimes virtual care is appropriate and sometimes in-person care is necessary. And so what I would tell any program that is thinking about either continuing or making a more definitive move towards a platform for long-lasting continuous care that involves virtual care is to first just think about who are the people that you're providing the service for? Which are the patient populations where this may benefit? Who are the providers that are comfortable doing this? And I try to tell any organization, it doesn't have to be all or nothing. You can have people who in some situations are comfortable with virtual care for certain issues, but for others aren't. And that's okay. And as long as we are flexible and agile in allowing a mix of blended care, we're probably going to be more successful in using virtual care across the board. If we're getting started, there's a few quick things that you can do. And one I like to call is quick wins. If there's a problem you have and you're having trouble solving for it, that's a great way to use virtual care. So if you just need to do blood pressure checks and you trust that your patients have a good blood pressure cuff at home, do they need to come in for a nursing visit because we have a nursing shortage? And the answer may be no. That's a great place for my practice to use virtual visits. And there are many such examples where a virtual check-in can be appropriate and can really get you over that hump of something you were trying to quickly solve for, and then also prove to your constituents, patients, care team alike, that this is a good technology and worth using.
When the COVID pandemic hit, I think there's kind of a scramble across the world, really, to try to create telemedicine programs. And at MGH, what was the trigger and what transpired to quickly throw this thing together?
Yeah, we were really fortunate. Lee Schwalm was the head of our telemedicine, and we had started and been very successful in the stroke population, providing remote acute stroke care and consultation throughout the New England area. There was a benefit to patients, there was a cost benefit. And so that had started back in the early 2010s. Once we saw that happen, myself and others in a variety of departments started to use telemedicine, recognizing its importance. And so the fortunate thing for the Mass General system and for our cardiology division in particular is that that system was already in place and really just needed to be activated for the rest of the practitioners. We were fortunate in that. There are some other large centers who had that. Many others had nothing and really had to say, what are the tools out there? Who are the telemedicine companies, of which there were many, who could quickly, in a HIPAA secure, safe way, enable us to connect with our patients. And so for that, there are many options that people can have. Looking forward, I think what brings success to this is having infrastructure. And that doesn't just mean having hardware or software or technology. That actually means having workflows. So one of the hardest parts we talk about a lot is provider adoption or patient adoption of new technologies. And I would say one of the greatest barriers for us to be effective in getting a new technology into healthcare is when we don't have a workflow as to how and when to use it. So I do like to remind people we were successful because we had the infrastructure. What took work was figuring out the workflow, teaching that workflow to people. And those people are not just the clinicians or the patients. They're anybody who interacts with a patient or clinician. They're the administrative staff who maybe carry the largest burden of teaching digital literacy to individuals on both sides, whether a practitioner or a patient. So, we were fortunate. We were able to turn on the software, we had the hardware, but again, we too, like many others, had to develop the workflow to keep this going.
what infrastructure did you have in place? Obviously, there's an IT component to this. I've heard of hospitals using, Zoom meetings and things like that. But in the world of HIPAA compliance and the way things should be wired, what technology did you use, and what do you see out there in the industry?
Yeah, so again, without a reflection on the companies themselves, just in terms of kind of stating facts, we had started with video with SBR, which was one of the original platforms. We had tried In Touch Health along the way, which was another platform. And then recognizing the volume of visits that were going to be done, we moved to Zoom for healthcare, right? So HIPAA compliant Zoom. There are other companies out there which people did use, and a fallback for many of us was the Doximity platform, which originally was only doing kind of phone calls that would, appear to come from your office, put you in a privacy connected way with your patients, and we're quick to beta and then move to video to allow you to see your patient during those COVID times, which were challenging, and there are many others as well. So that was kind of our route at the time.
While it might be convenient, what about the reimbursement angle on things? Because I think that was the major holdup with telemedicine leading up to the COVID pandemic.
Yeah, so, it's interesting. I didn't even know the governmental affairs office existed until a couple of years ago, right? Because then you get into telecardiology and then these things become important for us to know, which is our government needs to know what to do and how to support things. And we have been very fortunate. In Massachusetts, Governor Baker was very early in March of the pandemic to say, go ahead and do those televisits. We're going to compensate them the way in-person visits are, but we need healthcare to happen. That was very forward thinking at the time. I think similarly, we have many waivers kind of moving forward that are continuing to allow us to provide telemedicine care. Cross-state care has been a challenge. There are some states who have pacts among them where we can be licensed across states to provide that kind of care. Other institutions are working very hard to help their physicians be licensed in the states where they're providing care to patients. But I think reimbursement, there are so many different pieces of legislation that are in Congress now and moving forward, and many of them are emphasizing the fact that there is a need for virtual care. If you ask whether or not virtual care is as good as in-person care, I will tell you that the idea that there's a hierarchy where in-person care is best, then video, then phone, then text, or asynchronous, sending you a question or having you answer it offline, that hierarchy is not true. And so, to anybody who's thinking that hierarchy is existing thing, there are certain cases in which, I'll give you an example. There was a beautiful study looking at different ethnicities and the number of times that blood pressures were able to be measured and managed between clinician and patient. And this was a Black mother's study, a beautiful job supported by the Associated Black Cardiologists, and really showed that text messaging was one of the greatest ways to ensure that the communication was happening steadily compared to asking a new mom to come in, right? Or a new pregnant woman to come in and check blood pressure. And there are many such studies that talk about the fact that the gold standard is not in person. Gold standard is what is the best way to communicate with your patient and decide what is next. And that varies. And that's the flip of the switch that we need to make as clinicians. It's not the patient comes to me and gets the best care. It is what is the best care for my patient and how will I provide that? And so I think that's really important. Once we understand that, it becomes easier to then reimburse for those types of technologies, recognizing that what we have to do is show quality and outcomes. And that's where a lot of our research now is going in implementation science to kind of prove those points and give it back to Medicare and Medicaid and say, here you go, see what we're doing.
So CMS early on in the pandemic, they said, do whatever you got to do. Let's make sure that we get patients covered and that we can keep patients out of the hospitals and out of the clinics, if at all possible, to reduce transmission. But we've evolved into this new normal, and a lot of patient visits are becoming more and more back in person. There's still a large effort, it appears, amongst a lot of the medical societies to push Congress to keep those reimbursements in place. And where are those at, and what is the future bode in a post-pandemic world?
Yeah. I wish I had my crystal ball here today because that would be great. I think there are many of our government representatives who recognize the importance. I think there are many states where in-person care was really just not happening, right? Where getting to care was so hard. And now we're able to deliver care in those areas. Granted, there's still some challenges in terms of access and how you reach those people. And so I think, a lot of our government representatives now understand the importance of blended care, the importance of allowing some virtual care and some in-person care, and letting clinicians and patients use their own clinical acumen and personal experience to express that they understand what is also best for that relationship. And so I think that's why you see many of the societies coming forward supporting this a continued look at how to deliver virtual care, because we have to trust that there is, in fact, probably a better way to provide care than what we used to. Episodic care for population health is not ideal. Checking someone's blood pressure twice a year is not the best way to keep them under control. Continuous or at least more frequent monitoring touch points is. We know that for heart failure, we know that for diabetes. It's been proven in many different arenas. And so again, moving from episodic to continuous care naturally requires not just supporting in-person interval visits, but supporting continuous monitoring of patients, more continuous and easy communication in order to help patients engage with their own healthcare and really become the strongest self-advocates that they can.
Do you think that there's a paradigm shift now that people have had a taste of this actually propel this into the future?
Patients were there a lot earlier than we were. The patient experience metrics with virtual care have been through the roof since the initial studies were done, and that's been years now. So it's most certain that patients understand that value. They also know how to advocate for themselves when they want an in-person visit for a reason. So I'll tell you, I guess, two different things. One is a quick story. I was certain that one of my patients needed me to hold his hand to tell him he needed a third surgery. The time had come. I had seen it. I wanted to sit down, and I was insistent with my administrative staff that he come in, and he was insistent back with them that he'd done a virtual visit with me before, and he just wanted that. And when we finally had the visit, he said, "Thank you for accommodating this, because I need to be at home with my 3 kids to remind myself of why I'm going to have that third surgery. That's where I need to be." And the number of patients like that who say, being in the hospital and crying the whole way home to Maine, right? Being in the hospital and smelling the hospital, and the smell of the hospital, I've been told by my patients, changes when you know you need to come back for a big procedure. All of a sudden, that sterile scent is a trigger for some people. So there are all these stories of patients for me and others who really see the value in being in their own space, in their own home, on a level playing field. And as you mentioned, not missing work. Hourly wage workers, that's a very expensive thing to come in. It's actually expensive to also, come in and park in Boston, right? And so there's a lot of cost to it. There's time. There may be childcare or elder care they need to find. Transportation may not be easy. And there's a bit of anxiety that comes to all of us when we have to go through that whole process to get into a hospital, to a clinic, right? And are we thinking slowly? Are we our best selves in explaining things as clinicians? Are we our best selves as patients in understanding when we're in that hectic environment? Perhaps I would argue the calmer conversation from the physician or nurse sitting in a desk on Zoom, healthcare approved Zoom, with their patient sitting at home, maybe that's a conversation that actually is more meaningful and is making a larger impact, where people are hearing what you're saying better because you are calmer.
Great. I appreciate your overview.